Hi everyone, this is Katie Ilten, and I'm joined by Marguerite, Ahmann, Andrew Holm, and Chelsey Jonason. Good morning to those on the West Coast, happy lunchtime to those in the Central Time Zone, and good afternoon to those on the East Coast. Glad to have you today. We are going to jump right in just a minute to our grab bag FAQ webinar, which you tell us in your survey responses is one of your favorite types of webinars that we do. We're going to be buzzing through 20 to 30 or more questions that we get pretty often from clients, and hopefully giving you good practical tips for and answers to those questions. If you have a question that's been plaguing you or that seems to come up all the time but that you don't have you need the answer for, please type that into your screen. If you hover at the bottom of the screen, a chat box should show up, and you will be typing your question just to Robert, our IT person here, and he will hand it off to us, and we will try to take as many as we can of those throughout the presentation as it makes sense, and then certainly try to fit some in at the end. So please send your questions our way. We do have a number of questions that we received in the weeks before this webinar from folks, so to those who sent those, thanks so much, and we're going to try to get to all of them. Just a couple housekeeping things. Typically over the lunch hour, for the folks who are over the lunch hour for this webinar, the internet can be slow at organizations, and so if the audio cuts out, please use the dial-in number that was provided to you for this webinar, and then you can hear it at least over the phone. Our next webinar will be November 20th. That's actually the third Wednesday in November. We typically do these on the second Wednesday, so like today we're off 1 week. So watch for an invite for November 20th. Ryan Johnson and I will be talking all things telemedicine, from structuring transactions to billing questions. So listen into that, and if you have any specific telemedicine issues you're dealing with and want to send them our way, we would love to know what your questions are, and we will try to fit them in. In December, we will do our annual fee schedule new rules update, which is always a popular topic, so watch for our December invite as well. And then finally, we value your feedback. We base our webinars on your feedback and what you want to hear and what you don't want to hear, so please do provide it. And do note that if you have a question that you want to be contacted directly about in the survey, those survey responses we don't know who writes them, so if you want to be contacted, please include a contact for you so we can reach out to you. Without further ado, I'm going to hand it off to our colleague Andrew Holm.
Thank you, Katie. So the first slide here, can I disclose PHI to a potential buyer in the context of a deal? The short answer is yes, under HIPAA. There's a regulation that expressly authorizes the disclosure of PHI to a covered entity by a covered entity who's the seller. So the seller can disclose the PHI to the buyer both during diligence and also at closing when the records and assets are transferred to the buyer. Note that this authorization is granted under HIPAA, so you'll want to check state law too, which may be more restrictive. I work with several private equity-backed clients and often get the question about whether the regulation allows disclosure to a private equity sponsor or support organization who's not a covered entity. That disclosure is not allowed unless the buyer will be a covered entity after closing. So you can disclose to a non-covered entity who will be a covered entity following closing. That's a way around that hurdle. Do I need a BAA? Some buyers or sellers will request a BAA between the selling covered entity and the purchaser prior to closing. I don't think this hurts, but it's not clear that it helps either, because the BAA is used when a third party is going to perform services on behalf of the disclosing entity, and in the deal context, the buyer is not acting on behalf of the seller. But if the buyer wants to disclose to its consultants or advisors, the regulation would allow disclosure to the buyer, who could then who could disclose under a BAA with its advisors. Another question that frequently comes up, it's not on the slide, but what happens if the deal falls through? So you've disclosed PHI to a buyer, the deal's dead, what do you do? We'd recommend including language in the letter of intent, the LOI, that would address this scenario. So you could include a provision that the parties will comply with healthcare privacy laws, and even take it a step further and call for the return or destruction within a certain amount of time or once the negotiations terminate. And in all cases, make sure the disclosure is tailored to be the minimum amount necessary. So next question, I'm closing a clinic, what do I need to do? Well, first, tell your patients and help them find a new provider. Ideally, you would be able to stop scheduling patients after the date of closure so that you'd see all your patients and they would be able to transition to a new provider. But if you do have patients scheduled after the date the location is closing, do what you can to help them transition to a new practice. Call colleagues, see if you can make arrangements. I think that's the right thing to do, and it can also help reduce maybe a complaint to the board, likelihood of a complaint to the board, or a patient abandonment claim. So help transition those folks, will reduce that risk. You want to make arrangements for maintaining patient records. These requirements will vary by state, but you generally, after the last date of treatment, need to maintain the records for a certain number of years. If you're selling the practice or the location, you can require that the buyer agree to take on that responsibility. You could contract with a vendor. But in any event, make sure that arrangements are made and that the patients know who to contact to get their records. You want to notify boards or licensing agencies, medical board. Maybe you have a permit for x-ray machines or other equipment, DEA license or certification. If the practice location or providers there have a license or permit, it's important to provide notification. You want to notify employees. They'll need potentially to move on to another job, so make sure that they know what's going on. And then wind down the business. There are a lot of businessy things like paying vendors and terminating agreements, closing bank accounts and lines of credit, terminating leases for equipment or office space, disposing of medical equipment, maybe changing insurance coverage if you need a tail or no longer need certain policies, terminate benefit plans, and notify payers. And don't forget about accounts receivable. You may want to keep somebody on staff to collect AR if that's not outsourced. And then you may need to dissolve the business entity if it's not going to continue. You can contact a lawyer about that. It will require some filings with the state and perhaps some sort of published notification. So next slide, do's, don'ts, and maybes of delegating to support organizations. I work with a lot of dental or medical support organizations. Those are business corporations that, that contract with professional entities to provide administrative services. And so we often get questions about what is permissible for a professional entity to outsource to a business corporation. So first, the do's. Do outsource administrative functions, things like scheduling staff, hiring unlicensed individuals. Do document the arrangement in writing. It's important to have a written agreement that covers the key terms, compensation, the services to be provided, the length of the relationship. You want to document those in writing. Regularly review that agreement so you are evaluating whether you need the services that the support organization is providing, and that the services that are being provided actually track what's in the agreement. So dust that off and take a look at it from time to time. You'll want the practice entity to retain authority over hiring and promoting licensed individuals. So the practice, if it's a medical practice, should have the authority over hiring physicians, for instance. Review the communications from the support organization to the staff. So if there are communications about treatment options, things like that, things related to the provision of care, you'll want to definitely review and approve those as the practice entity. And then review state law. Things that are permissible can vary widely from state to state. So if you're in multiple states, it's important to know the differences between the states. Things that you generally don't want to do, don't delegate clinical decision-making authority to the support organization. Don't allow the support organization to decide compensation for your licensed or certified individuals. So for medical practice, the owners of the practice should decide and set the compensation for the physicians on staff. Don't accept financial assistance from a support organization that won't be repaid. It's important to maintain the financial separation or independence of the two organizations. And don't let the support organization determine whether to prioritize certain high-profit procedures or payers. There was one big New York Attorney General opinion where a dental organization got in hot water for that. Things you can maybe do, it may be permissible to transfer ownership of medical equipment to the support organization or dental equipment, or lease the office space. In some states, the practice entity needs to own the equipment or at least operate the office space. Some states prohibit the use of a trade name that isn't the name of the practice entity or the name of the actual providers. So that can vary from state to state. And you can maybe call a healthcare lawyer with questions about that. The next slide, I heard about a big decision in the AseraCare case. What happened? So this case came down from the 11th Circuit last month, it was mid-September, and it involved a False Claims Act claim by the government based on AseraCare's certifications that its hospice patients were terminally ill. This is a determination that means the patient's prognosis is that he or she has less than 6 months to live. Some patients live longer and are in hospice for longer, and those patients can continue to receive the hospice care, and they would need to be recertified periodically. So the government brought a claim alleging that AseraCare's patients were improperly certified as terminally ill and were therefore getting hospice benefits for longer than they should have been. The government presented expert testimony at a trial from an expert who concluded that a number of AseraCare's certifications were false. The jury agreed and found in favor of the government, excuse me, but the trial court actually set aside the jury verdict and ordered a new trial on the ground that the government needed to demonstrate an objective falsehood in the certification. It wasn't enough for the government to just put up a competing expert. There actually had to be an objective falsehood in AseraCare's certification. And the Court of Appeals agreed with that determination. So the court provided some guidance on when an objective falsehood could be shown, provided 3 examples. For instance, if the certifying physician doesn't review the patient's medical records or doesn't review all of the records, but certifies the patient nonetheless, that could be an objective falsehood that would give rise to an FCA claim. If the physician doesn't subjectively believe his or her own certification, that's another ground that could give rise to an FCA claim. Or if no reasonable physician could have certified the patient as terminally ill, then that could give rise to an FCA claim. So the case was remanded back to trial court. It's in, I believe, the Northern District of Alabama for further proceedings to determine if the government could present evidence to prove an objective falsehood in the certifications, either through one of the methods that the court identified, or the court left the door open for the trial court to identify a different method for the government to prove an objective falsehood. So we'll continue to monitor that case, but for now, it's a win for providers because, at least in the 11th Circuit, stands for the proposition that an FCA claim can't just be based on the government's armchair quarterbacking after the fact through an expert witness. There has to be something more to the claim. Can I share the legal advice I get with others? Yes. If you're the client, you can generally do what you want with legal advice. I recommend listening to it, but if you'd like to share it, you can share it. But doing so risks waiving the attorney-client privilege and therefore making the advice discoverable. So beware of the email forward. Say you receive legal advice from your attorney, think twice before forwarding the advice, especially to individuals outside your organization. You can, in certain circumstances, share legal advice without destroying the privilege with a third party if you're defending against a common claim or you have a common interest, but that position is definitely not a slam dunk. Sometimes you can even waive the privilege by sharing the advice internally at the organization if it goes outside the group that needs to know the advice, or perhaps outside the higher levels of management employees that could destroy the privilege. So be careful of where the communications go once you receive them from the lawyer. I had a client once who had an employee that was communicating directly with the legal department and then putting those communications in the customer's file. The communications were about a dispute with the customer, and so lo and behold, those communications go in the customer's file and the customer has access to them next time they log into their account online. So obviously there was a privilege issue there, and that situation risks waiving the privilege. So be sure that you know where communications are going once the organization receives them from the client. Another issue that comes up frequently is whether copying a lawyer on a communication makes the communication privileged. It can't hurt, but it's not a guarantee, and this is generally because in order for the privilege to apply, the communication has to be between a client and a prospective client and the lawyer seeking legal advice. So for instance, if the lawyer's copied on communications about a business issue, just adding the lawyer to those communications won't make them privileged. Similarly, if the lawyer's copied as an FYI, but there's not a request for legal advice, that also may not make the communication privileged. So takeaway, if you want to help maintain the privilege, make sure that communications from the lawyer aren't forwarded. And it's always easy to pick up the phone and if you have a question about a specific communication, call the lawyer and ask what you can do to help ensure the privilege attaches. Can I give gifts to patients? Generally not if the patient's a Medicare or Medicaid beneficiary and the remuneration or the gift is likely to influence the selection of a particular provider. There are some exceptions to this rule. One is the nominal value exception. The OIG has provided guidance that if the value of the gift is no more than $15 per item or $75 in the aggregate annually, the gift is of nominal value and would be permitted. This was just increased in 2016 from $10 and $50 respectively. Note that the items cannot be cash or cash equivalents, so things like a prepaid Visa gift card or a check would not be allowed. Other exceptions include preventative care in certain circumstances and copay or deductible waivers based on financial need. And note that state law could be more restrictive, so it's important to check. Should my organization have a compliance program? Absolutely, if you want to qualify as a Medicare Advantage organization, but I think it's a good idea regardless. The OIG has provided some helpful guidance regarding voluntary plans for various entity types, including hospitals and others, at the website listed on the slide. These plans are helpful if you're ever faced with an investigation or an audit. They're even more helpful if they're routinely dusted off and updated, and even more helpful if employees and contractors are trained on the plans and comply with them. And just to note that this type of compliance plan is not a substitute for a HIPAA compliance plan or security risk assessment. So I will turn it over to Chelsey Jonason now.
Hi, this is Chelsey Jonason. My first topic is about video cameras in hospitals, and we've been seeing this issue get some attention recently. So the first place I'm looking here is for hospitals to look at the CMS's Conditions of Participation Manual. It's going to address this issue, but don't forget to check your state's privacy laws and enforcement related to video recording. So as far as video monitoring goes, we're usually thinking about safety or clinical reasons. The key seems to be patient awareness. So we recommend that you're posting signs alerting patients that video monitoring is occurring. You want to use extra caution in private areas like bathrooms and dressing areas. If you're going to be recording patients, then you should be obtaining patient consent or the consent of the patient's representative. One more, don't forget, you also have HIPAA and state law authorization requirements if you're sharing the recordings. So back in 2018, 3 hospitals collectively paid OCR $999,000 to settle potential HIPAA violations for actions related to filming of patients for a television show. That was not looked upon favorably by OCR. All right, up next, declining Medicare patients. So if you don't have a provider agreement with CMS, then you can probably decline Medicare patients. If someone is going to get mad at you, it's likely going to be an ethics inquiry from the Board of Medicine. Medicare does not require you to do services for people. There is a possibility that a patient could assert an age discrimination claim, but we're not aware of a situation where that argument has been successful. If you do have a provider agreement with CMS, for example, you're a Part A entity like a hospital, an ASC, or a SNF, CMS can terminate that provider agreement if you impose restrictions that don't apply to everyone. This could be a violation of the Conditions of Participation. Now, on the other hand, we have Medicaid. So declining Medicaid patients is a hard question to answer because the answer is going to be very state-specific. States create their own rules and policies for their Medicaid programs. Most states do have an anti-discrimination statute for Medicaid recipients. Generally speaking, discrimination against Medicaid patients will be problematic. Also, watch out because declining Medicaid patients could mean that you aren't eligible to see patients in other state health care programs. All right. Can I bill Incident 2 in the hospital? This is a question we get pretty often. So Incident 2 billing is where one practitioner begins a course of treatment and then auxiliary personnel, be that other practitioners, nurses, or aides, provide service in that course. And even though the physician who started that course of treatment isn't the one doing the services, they are supervising the services. And the clinic gets to bill at the physician rate, not the lower rate for providing the service. This is financially attractive. So the basic fact to remember is that Incident 2 billing is only allowed in the clinics, not in the hospital. This includes not in the outpatient hospital departments like psychotherapy. Our colleague David Glaser did a deep dive into Incident 2 billing back in May of 2018 on a different webinar, and that webinar is available on the Fredrikson website. The Physician Payment Sunshine Act. So the Open Payments Program is requiring applicable manufacturers and GPOs to report certain payments or other transfers of value provided to physicians and teaching hospitals, and any ownership or investment interests that physicians or their immediate family members have in the applicable manufacturer or GPO. The reports of these payments are available on the CMS website. Failing to report can result in steep civil monetary penalties of not less than $1,000 to not more than $10,000 for each failure to report for each failure to report, with a total annual reporting year CMP cap of $150,000. The penalties for knowing violations are even higher. So back in March of this year, Senators Chuck Grassley and Ron Whedon wrote to the Department of Health and Human Services regarding the potential failure of physician-owned distributorships to disclose physician ownership interests and related payments as required under the Physician Payment Sunshine Act. The senators refer to the POD relationship as inherently suspect because they believe it could encourage physicians to perform unnecessary surgeries or to choose a device which they have a financial interest for the purposes of generating more profit for the POD and thereby themselves. Since that time, we have had clients who have received enforcement letters from CMS. Let us know if you have questions about whether and what you need to report, and we can help if you receive one of these enforcement letters. All right, out-of-network billing. So this is a thorny issue, and I recommend that you get in touch with our colleague Lori Hartman if you're having issues with this. But in short, it's hard to predict what you're going to get paid. Collecting out-of-network claims is usually harder than collecting contracted claims, and out-of-network claims may be scrutinized more carefully than contracted claims, so you want to make sure that you're submitting accurate and complete information. We think it's worth negotiating and pushing back when you don't think that you're getting a fair rate.
All right, this is Katie Ilten. So we often get the question about whether you can offer a prompt pay discount. So the answer depends a little bit on sort of what the rationale is. So the first thing to be aware of is that offering discounts can sometimes implicate the Truth in Lending Act. So if you're offering a discount, but it really is more like a loan where someone has to pay over time, or you're offering a delay of a loan, you need to make sure that depending on how many installments the loan may be paid in, that you're complying with all of the state and federal truth in lending statutes and disclosures. If you are going to offer a prompt pay discount, the rationale would be that you are basically taking the discount because you would otherwise have to pay money to collect the fee later. You may run into issues with doing this under insurance contracts because the insurer may characterize this as basically a billing fee. It really is going to depend on your insurance contracts, and they may not say either way. Watch out for the billing fee prohibition because sort of a categorical prompt pay discount may be tagged by your payers as having an issue. Another question we get a lot is, can we offer free transportation? And in fact, one came in as we were starting off the webinar. So the free transportation question is really fact specific depending on the sort of system you want to set up. Free transportation really brings up federal and state law concerns or potential concerns. So you have the federal anti-kickback statute that prohibits intentionally offering or receiving payment with the intent of inducing referrals of federal healthcare program business. You have the CMP stands for Civil Money Penalty Law, and that's a federal law that is specific to offering remuneration specifically to and directly to beneficiaries. And that's the law that Andrew was mostly thinking about when he was talking about giving gifts to patients. So we often forget about CMP because we just think about the kickback law, but CMP actually says you're not supposed to give things directly to patients. So free transportation may certainly be considered remuneration. And then a lot of states have different sort of kickback referral prohibitions as well. And for several years, the OIG would opine on specific free transportation arrangements. And there are probably 7 to 10 OIG advisory opinions out there that analyze some sort of free transportation program. And from those advisory opinions, we would sort of gather the various factors that seem to make certain arrangements less suspect than others. And we would sort of kind of think of those factors and give that advice to clients to incorporate those factors into their programs. The government's perspective on this became a lot clearer in January of 2017 when they promulgated a new regulatory safe harbor to the anti-kickback statute and an exception to the beneficiary inducement prohibition. So there are actually now, if you're structuring a free transportation arrangement to fit within one or both of those safe harbors or exceptions, then you can now do that and have cover with certainty. There are certainly situations where folks want to have a free transportation program that might not fit within the exception or the safe harbor. And remember that just because you don't fit under a safe harbor doesn't mean that conduct is illegal. It's just that it's potentially going to be examined. So the safe harbor has a couple of different prongs. It basically says you can provide free or reduced transportation if you have a policy, and that policy is about who gets the transportation, and the policy, doesn't base who gets the transportation on whether or not the person is coming back for more services or the volume of those services, and you apply that policy consistently across the enterprise. So you have to have a policy to start with if you want to meet the safe harbor. You can't have any free air transportation or reduced air transportation or any sort of luxury type of limousine service in order to meet the safe harbor. And you can't do ambulance level transportation, again, to meet the safe harbor. This is folks often want to do air reductions or, nicer transportation or maybe free non-medical ambulance transportation, and that's not going to fit within the safe harbor, but you can look at some other factors that would reduce your risk. You can't market the program outside, you can't put up billboards that say, we health system offer free transportation if you want to fit in the safe harbor. And you can't pay the transportation provider based on the number of folks that you're getting to and from your sites. The program should be offered only to established patients. So established would mean, within kind of reasonable person speak, someone who's been a patient before, someone who has a scheduled appointment, someone who's started a course of treatment, not a new patient. There is a geographic limit. You can only provide this free transportation within 25-mile radius. If you're rural, you get a little bit more room if you want to fit within the safe harbor. And you can only use it for obtaining medically necessary items and services. Now, you can take people back to their homes, but you couldn't do it for like medical transportation, like you're taking people to other appointments that they might have in the community that don't have to do with the care. And then, of course, the provider supplier has to bear the cost of the free transportation. So there is now a little bit more crystallized, I guess, safe harbor that you can try to fit in if you want to do it completely without risk. The other part of this safe harbor says that you can have local shuttle services that are just kind of running, like a bus service that's running between sites, and those are going to be okay so long as they meet the safe harbor requirements. But in that situation, you don't have to limit your shuttle service to established patients. That can be broader, and you're still going to fall under the safe harbor, and that's for the less than 25 miles between stops. So it's interesting because you might have a shuttle service that goes into rural areas and stops. You don't have to have a main hub. You could do 25 miles between different sort of spoke sites. So that, I think, possibly allows a little bit more room than just a main hub site with going back and forth to it. So if you aren't going to have a program that fits within the specifically and within the safe harbor, you want to keep a couple kind of principles in mind. Generally, it's better to have free transportation or reduced transportation that's going between sites. A couple of the advisory opinions had looked unfavorably on providers who were taking people back and forth from their homes. That seemed to be, I guess, to the government a little more of a little higher of a value, and they liked more site-to-site transportation. So that's one thing to think about. It certainly always helps in these sorts of scenarios to get on the government's good side if you have some financial means testing happening. So not offering it to folks who do have a financial need for it. You know, a big no-no is definitely don't only offer the transportation to people who are going to have treatments that are higher dollars. Now, it's certainly the case that sicker people may need more transportation, and I think that that is a fair, defensible position, but you do not want emails going around your organization that say, hey, this particular course of treatment, there are more visits and, we rake in more insurance dollars because of it, so let's offer it to people on this program and not others. I don't think that's what's happening in most cases, but I certainly have seen it, and that's really going to be a problem. And then if you're doing transportation way outside your service area, it's riskier. It's harder to justify that cost, and it looks like it's more value to the beneficiary, and so you want to watch out for anything that's extending beyond your service area. One person had asked the question about the unique scenario of where the county offers transportation using county buses, and the provider is opening an office in a remote city in the same county, and they asked whether or not they could contribute money to the county to get expanded bus service to that location. So that's an interesting variation on this theme. I think that when you're providing money to someone who is not the beneficiary, or the value is going to go, the value may indirectly go to the beneficiary by having that shuttle service, but the dollars are going to like a foundation or the county. You're going to be in a safer zone than if you're, providing transportation directly to people to and from their homes. So I think that helps. That scenario makes me feel even better because you are the county is the one that's making choices about how to use the dollars. Another interesting question that has come up deals with this increasing frequency of secure, or maybe not secure, texting with patients. So this person said, we use secure texting for reception and nursing to communicate with patients, one way to them. So I guess they're just sending messages but not getting responses. Do we need to ask IT to develop a log of these texts? For decades, we have made calls to patients and do not record what was said. There seems to be a push to keep these text records, but I'm not seeing the difference. I'm interested in your comments. This is really interesting because I know that there are more ways to communicate with patients, and certainly text messages happening, and lots of automated text messages for that matter. There's not a legal requirement to keep conversations with patients. I think the things that come up here are whether there's a treatment consideration. Are you texting with patients substantive information that that someone in the treatment team would need to know or would like to know if they see the patient subsequently? So I think you want to think about narrowing your messages with patients, whether it be email or text, to the things that aren't going to necessarily affect care greatly, so that you can keep all of that information in one place. The other thing that's different about texts versus phone calls is that the texts create a record, whereas phone calls, unless they're recorded, it's just the witness on the stand what was said. So I think the more things are written down and preserved, the more considerations you have with respect to malpractice lawsuits and the records that are available. So if the patient may keep information or may be able to keep recordings because they're texts or emails, it would probably be useful, depending on what's in those, for the provider to have those records as well. And this question raised an interesting, another one. Should the content of phone calls be documented? And certainly I've been in situations where the record has said a phone call was made, but there's nothing about what was said. And it would have been nice to at least have had a little bit of an idea what was said to the patient, because the provider said, well, no, I told them to take their medicine, or I told them to come to the ER, and the patient said, no, they didn't. And usually the content of those calls is beneficial to know from the provider's perspective. So just a kind of a thought for the questioner is whether you should consider keeping track at least of what some of the phone call content is, particularly if it's nursing clinical based. Got a question about public awareness and signage for public awareness. This person said, if a clinic enrolls a practice, so we're talking about clinics, if a clinic enrolled a practice location at a non-traditional setting, such as a high school, and leased the space as non-provider based to perform a service, is the clinic required to have signage, i.e. public awareness, at the leased space? Is informing the patient at the time of the scheduling where to go for the visit enough? So an important clarification here. This business about public awareness and signage that you've probably been hearing a lot about lately, because of the provider-based rule guidance that has come out, that is a Medicare requirement that's specific to provider-based departments of hospitals. So clinics, unless there's a state law or some insurance requirement, clinics that are freestanding, i.e. not hospital clinics, don't have to have signs about who they are and who's entering what type of building you're entering. The public awareness is a piece that is required of hospital departments, so that the patient knows when they're walking into the space that they are going to be billed as if they are a hospital patient, which in many cases means, at least for Medicare, they're going to get two bills. They're going to get a hospital bill and a professional service bill. And that's the policy behind the public awareness, is that where the spaces are that are hospital-based but aren't obviously hospital, the government wants people to know what their billing insurance liability co-insurance liability is going to be. So speaking of that provider-based guidance, what in the world is the status of it? We had a webinar back in June that followed the May 19 release of the draft guidance. We talked a lot about the questions we had from the guidance and what it means, and I think industry generally had many questions, and I know I've heard from CMS and people who work with CMS folks that they were inundated with comments. And so thanks to many of you who I know sent the comments. Those comments were due in July, and I have not heard sense of when we can expect that guidance on co-location to come out. If you have heard, I'd love to know, but right now I have not heard any timeline expectation. We will see the final 2020 OPPS rule in November. It's possible they'll mention something, but what came out was guidance to surveyors, so I doubt we're going to see anything coming into rulemaking. We'll have to see in November if they mention anything. All right, moving along here, we get questions about IDTFs quite a bit. What exactly is an IDTF? So an IDTF is a funny thing. It is a Medicare creature, and I've put up the regulation that describes what an IDTF is. I always have to pull this when I'm describing it to people, because basically an IDTF is something that is a diagnostic testing facility that is not a physician office and is not a hospital. So one might say, why would anybody want to be an IDTF? And certainly, if you're a physician group, I don't know why you'd want to be an IDTF. I think that it comes with a lot more requirements and certainly a lot more regulations than just being a physician group that has imaging in the office. I think most IDTFs are created because the owners are not physician groups and they're not hospitals, but they want to do testing. Otherwise, I can't think of a reason why a physician group would open one unless they were trying to open something in a place where they couldn't also have an office, in which case, to be freestanding imaging, you'd need to be an IDTF. So several more questions by this person. Is an IDTF a physical place where patients go for testing? Yes, it is a facility. If so, how is the technical component of the test billed? What place of service is reported? This is a good question, and one that's not answered very clearly by Medicare. The Medicare guidance says that basically if you have a mobile ID, so you can have a mobile IDTF, but it's still, it still has to be enrolled separately. If you have a mobile IDTF that goes to a beneficiary's home, the place of service reported is the home. Otherwise, I think you have to report the place of service independent clinic, because that's the only one place of service on the list that I think fits the IDTF situation. You can't say it's a physician clinic, because that's not what it is. So that's an interesting and common question we get about place of service. What must the IDTF employ the interpreting physician? So there's no requirement that an IDTF employ someone who's interpreting the images, but the thing you want to think about when you have, when you're not employing an interpreting physician is that you may be subject to the you will be subject to the Medicare anti-markup rule if your interpreting physician does not share a practice with the IDTF. So if you're contracting for it and the physician isn't on site, or they don't provide a substantial amount of their services through that IDTF, then the IDTF itself is not going to be able to mark up the interpretation. So there are just a lot of extra rules for IDTFs. They can't share a practice location with anything. You have to enroll each location and every mobile unit separately. There are limits to how many places a supervising physician can supervise. That isn't the case for group practices that have imaging with supervising physicians. There's no limit on a physician group practice person who's supervising. Importantly, an IDTF has to have written orders. That's different than a physician group or a hospital where you have to have an order for a test, but it need not necessarily be written. And there are rules about soliciting patients. So to go back to the questioner, I don't know why you would do this unless you absolutely had to. Hopefully that sheds some light on the decision you might be making. Oh, I should note that I think a reason that a lot of folks out there think physician groups must be IDTFs is because there was old manual guidance that existed in 2008, and I think it went away in 2010. And that manual guidance basically said, if you're a physician group and more than 5% of your overall business is from outside scans, i.e. scans your group doesn't order, then you must enroll to be an IDTF. That manual guidance, well, first of all, there weren't that many physician groups where more than 5% of the whole business was outside scans. I can't imagine a group that would have that situation. So even under that old manual language, it's unlikely that you would have had to be an IDTF. And then that manual language was just manual language, not regulation, so not binding law, and it's gone. So hopefully that helps dispel any remaining myths about one must be an IDTF if you're a physician group. So my last little point here before I turn it over to Marguerite Ahmann is a question that we got about the 2 midnight rule. We still get a lot of questions about when someone can be an inpatient for Medicare purposes. And the 2 midnight rule seemed to, certainly in my mind, clarified that, but it seems that people are still quite confused, and I think because Medicare has not cleaned up its guidance on this point. So this was not a new bit of guidance, but new to me in knowing that the guidance that's out there that still exists is not necessarily consistent with the regulation. So the questioner was asking about this red language that said basically the situation, I guess, under this language is that there would have been an order for inpatient admission, and then apparently in this scenario, if there's a practitioner who's responsible for authenticating the initial order, and that practitioner disagrees with the initial order, in that case, the guidance is telling us that the hospital stay is not going to be an inpatient stay. Now, I'm not sure how often it would be the case that a second person would disagree with the physician's initial order, but let's just say that that did happen. The fact that someone later disagrees with the order under the regulation doesn't mean someone is not an inpatient. And so if you are to look at the specific 2 midnight rule regulation, it says that inpatient admission is generally appropriate for payment when the admitting physician expects the patient to require hospital care that crosses 2 midnights. And if there is that expectation and there's an order based on the expectation, I don't think it matters if a second person disagrees. The order was valid and the patient is an inpatient. So just another example of manual language that hasn't, I don't know if it ever will catch up with the rule, but if you see something in the manual, make sure you check it against the regulation.
All right, this is Marguerite Ahmann, and I'm going to talk a little bit about the state of E&M. So we've had a number of clients wondering about the fate of evaluation and management payments, or E&M payments, because CMS has caused quite a stir over the past couple of years with first a proposal and then finalizing that proposal to collapse certain E&M coding levels. So as background, physicians and other practitioners who are paid under the physician fee schedule bill for common office visits and for evaluation and management using a set of CPT codes that distinguish visits based on the level of complexity, the site of service, and whether the patient is new or established. Within the office and outpatient setting, there are five levels of these codes. And generally speaking, as the code increases, so does the payment rate. So in the 2019 final rule, CMS finalized the assignment of a single payment rate for levels 2 through 4 within the office and outpatient setting, basically collapsing that rate into just a single payment. CMS responded to extensive comments in both the proposed and final rule for 2020. Sorry, just the proposed rule for 2020. We are still waiting on that final rule. And they have walked back this concept of collapsing levels 2 through 4. Instead, for now, they've proposed adopting the E&M code definitions developed by the AMA CPT editorial panel. And there are a lot of additional nuances to this proposal. We generally dive into those during our December webinar when we cover the final rules for IPPS, OPPS, and other regulations that come out at year end. So stay tuned for more, but in the meantime, there's no reason to panic over that one. All right, on to kickbacks in the EHR realm. So back in 2017, eClinicalWorks paid $155 million to resolve False Claims Act allegations by the government. The main issue there surrounded allegations that the company attested to having certain certification functionalities without actually meeting the certification criteria established by the ONC's Health IT certification program. A much smaller aspect, but really interesting aspect of that settlement was that it also resolved allegations that eClinicalWorks violated the anti-kickback statute by paying its customers to recommend its products to other prospective customers. eClinicalWorks was paying customers $500 per referral, and the government attributed that to about 3 to 5% of the company's new customers were coming from those referrals. So this isn't the traditional referral that we're used to. It wasn't involving an item or service directly reimbursable by a federal healthcare program. Instead, here the business reimbursable was the EHR incentive payment that came from the government to the providers. So at that point in 2017, the government didn't have to spell out its argument. This wasn't fully litigated, and it was merely a statement within the settlement. And since then, we have learned not much more. But we do know that it is still a focus of the government, and it's caused us to sort of reevaluate the application of the anti-kickback statute to incentive payments, certainly within the EHR realm, but also within value-based care and other quality payments that may be coming out. We know that it is still on the government's radar because they continue to enforce against EHR vendors. So in February of this year, Greenway Health, a Florida-based EHR vendor, paid just a little over $57 million to settle False Claims Act allegations, and again, a piece of that was settling allegations under the anti-kickback statute. And then Allscripts has reported that it's reached a tentative settlement of $145 million regarding very similar allegations related to its recently acquired Practice Fusion business. So it's something to keep on our radars. Unfortunately, we haven't had any sort of guidance or case law to fully outline what the government's rationale is regarding that one. All right, another area of uncertainty is the state of the conscience objection regulations. So as background, in May of this year, HHS announced final conscience rules, so protecting statutory conscience rights in healthcare. They were supposed to be effective as of July 22nd of this year, and the regulations were designed to permit healthcare professionals to decline to participate in healthcare that violated their conscience or religious beliefs. So this was aimed at allowing professionals to object from participating in abortions or sterilizations or assisted suicide. So after the final rules were published, HHS faced several legal challenges in California, New York, and Maryland. And as a result of those cases, they have stipulated and delayed implementation of those regulations until at least November 22nd, 2019. Since that, we have not heard much more on this, so we are in waiting mode on this one as well. HHS received just a flood of comments regarding the conscience objection regulations, notably from a lot of providers who are concerned about balancing their obligations under Section 1557 of the ACA and other anti-discrimination laws that pertain to their obligations to patients and balancing that against their obligations with respect to their providers in these conscience objections. So we will report back when we know more. All right, we are going to close out. We have just a couple more minutes, but a hot topic is always HIPAA compliance. And so Chelsey and I are going to finish up with some quick hits on HIPAA and health privacy related questions. So the first question is Chelsey's going to handle, and it's, can we send emails to patients?
Yeah, so just a quick note on this. For most covered entities and patients, this is not the ideal method for sending records to patients, but if a patient is going to request this method of communication, you should honor that request. CMS has recommended that covered entities give patients a light warning of the security risk, and then so long as the request is from the patient, then the covered entity is not responsible for the security risk associated with that transmission. Another one that we get with some frequency is subpoenas for medical records. My big warning here is just because a subpoena came from a law firm doesn't mean that everything is properly done. You want to make sure that service is proper, but then also make sure that the HIPAA requirements are met. One thing that I find is that a lot of times there's not actually an authorization from the patient, and you want to push back on that. So you can reach out to that law firm and make sure that those requirements are met. And then also, if they're trying to get your records custodian to come and testify, you can always push back and ask for them to get a stipulation with the other side, so you don't have to burden your records custodian with that.
All right, on to another fairly simple question is, do I need to do a security risk analysis? And the answer is yes. If you are a covered entity or a business associate, the HIPAA security rule requires that you do a security risk analysis. So the question is not whether you have to do one, it's a matter of how comprehensive that risk analysis has to be. There's just a ton of guidance out there from OCR regarding a risk analysis, what you should do while conducting one, how a risk analysis differs from a gap analysis. That guidance was put out in 2018, and I recommend you take a look because it emphasizes how comprehensive OCR believes that your risk analysis needs to be. So we will continue to plow through a few of these as I know we are reaching the end the time that we have today. The next one is, can we release medical records we received from a third party? And as we caveat through basically this entire presentation, you always want to look to state law, but under HIPAA, the answer is yes. HIPAA defines PHI as any health information that a covered entity creates or receives from other entities. So you are permitted to disclose your full record that you keep in your files when a patient requests. There are some restrictions if you are a program regulated under 42 CFR Part 2, the substance use disorder regulations. There redisclosure is not permitted without a patient authorization, so you want to take a look at those as well. Another question we get, this stems from some guidance that OCR put out in 2016 that significantly changed the game with respect to how much you could charge for medical records, and they posted that you could charge a flat fee of $6.50. So then the question we get is that really a maximum under HIPAA that's for copies of PHI? And they actually outlined 3 different methods in that guidance. You can do actual costs, the average costs, or that flat fee of $6.50. So there are a number of different methods that you can take to get to that charge. I think one of the most important factors that I saw coming from that guidance is their expectation that you communicate whatever method you are using to patients in advance, and that they understand what the costs are going to be in advance of being assessed that fee. Okay.
So I think we're going to skip to some of the, I think we still have people on, is that right, Robert? We still have folks on, and we have some questions that were sent in during the presentation, so I'm going to rudely cut Margie off, but I think she has some of these questions to answer too. So going back to the inpatient order discussion, got a couple questions on that. So one question relates to whether you have to have signed inpatient orders in the record prior to the discharge of the patient. So this is a really good question, and the answer has changed. It used to be the case that the CMS said in guidance that you had to have the inpatient order authenticated and or signed prior to the discharge of the patient. That wasn't ever actually even in the regulation, but people were refunding money because they didn't have authentication or documentation prior to discharge, and Medicare auditors were taking money back because of that reason. And CMS came out in, I think it was 2018 final rule, maybe even a year before, but in any case, CMS came out and said, oh, we really, really didn't mean for you to be giving us all your money back when you had a perfectly valid order, but it didn't have a technical documentation or signature piece completed by the discharge. We didn't mean it, and so even though it wasn't in the regulation, we're going to try to clarify the regulation to say, if you have an order, but it isn't, if you have an order that the physician believes the person is going to cross 2 midnights, and that is somewhere that's available to ascertain, then we're not going to deny stays later because you didn't have it signed. So that means that if you have in the record documented that someone thinks, the admitting physician thinks that the person can stay, expects the patient to stay over 2 midnights, that's an order, and you shouldn't be giving money back because it isn't signed. Now the catch here is that the order has to be by someone who has admitting privileges. So that's the hard case where you have someone admitting a patient based on the expectation they're going to cross 2 midnights, but that person doesn't have admitting privileges. If that's the case, I wish I had a better answer, but that's going to be harder to say you don't need to refund or the government can't take those dollars back. So I would be less worried about signing and authenticating and making orders look perfect, and I would be more worried about just getting written down that someone ordered, whether it was over the phone or in person or wrote it down, someone with admitting privileges ordered this inpatient stay, and that's enough under the rule. We have a question here about how often do I have to check the OIG exclusion list. So the OIG will tell you, I believe, to check the exclusion list at the time of hire, at the time of engagement of a contractor, and then thereafter, monthly thereafter. There's no law that says how often you must check the federal exclusion list. The government's line has been recently check it monthly. And if you are a Medicare Advantage contractor, it's likely that the requirement to check monthly has been pushed down to you by contract, so be aware of that. And then states are increasingly imposing their own exclusion list check requirements. For example, in Minnesota last year, we saw now that the Minnesota law requires providers to check the Medicaid exclusion list monthly. So we still don't have a federal law requirement, but I don't know if we'll see one. I haven't seen that proposed, but it's certainly the expectation that you're checking more frequently than several years ago.
So we had someone ask us to speak to the use of body cameras by facility security and law enforcement. So this ends up being kind of two very different categories. If you have facility security who are employed, let's say by the hospital, the same rules are going to apply as what Chelsey was talking about earlier regarding HIPAA and conditions of participation, because it would be very much the same as installing video cameras on the premises. If it's involving law enforcement, that's where it changes. So there's sort of a patchwork of different laws that you want to look to regarding what the implications are going to be of any recordings happening by law enforcement on, let's say, a hospital's premises. So there's going to be state government data practices laws that are going to dictate how that information could be disclosed. There are also going to be specific jurisdictional policies and guidance on when they're allowed to turn the cameras on and off. But from your position sitting within the facility and the hospital, your obligations are going to be determined largely by HIPAA. The number of disclosures that you can make to law enforcement under HIPAA are incredibly limited, and so the same is true with respect to these disclosures that would be made to a law enforcement officer that would then be recorded and potentially redisclosed when someone requests access to that footage. So you're going to want to treat it the same way as you would if you had a law enforcement officer coming in and asking for access to certain areas of your facility. You have every right to say no. And we actually had a recent webinar about ICE officials, but you have rights to protect your patient privacy in those records. So that will serve to guide how you treat law enforcement body cameras for now, and I would expect we'll see additional regulations in the future to address this sort of gap from a HIPAA perspective and federal regulation perspective.
All right, I'll do one more quick one, and then we might have another quick HIPAA one, and then we'll let you go about your day. Can we charge for missed appointments? So Medicare actually, I believe, has some guidance that says that you may charge a Medicare patient for a missed appointment because it's a missed business opportunity. But you should be aware that state Medicaid agencies may have different positions. For example, our own state Medicaid agency in Minnesota does not prohibits charging for missed appointments. So make sure you know there are various rules out there depending on the status of the patient.
Okay, we got another question regarding fee restrictions for records under HIPAA and high tech. And the question is whether those fee restrictions apply when a law office requests records on behalf of a patient. And so this is an interesting question. So the guidance regarding the specific fees that can be charged and the underlying regulation in HIPAA relates to the individual's right of access under HIPAA. So an individual has the right to go to a covered entity and asks for copies of their medical records, and the covered entity is allowed to charge a reasonable cost-based fee. When someone other than the patient requests the records, it is not subject to that right of access regulation and the subsequent restrictions on the fees that can be charged. I will note that there are often state laws that apply generally to medical records requests, so you want to look at those as well. How this comes up, though, is that a lot of law offices, when they are requesting records, are forwarding along a direct request from the patient. So they understand that this regulation exists, and so they will frame the request as them serving as a third party merely to transfer on the individual's request for access to the records. So you need to look closely at the form of the request and make a determination on whether or not that falls under the individual's right of access.
So thanks to those who are able to hang on after. We appreciate it. This always goes really quickly, and we'll keep doing our FAQ webinars. And so if we didn't get your question, we'll try to reach out to those that we didn't get to. And please fill out the survey. Join us in November 20th for telemedicine, and hope to talk to you then. Bye now.